So to continue my presentation about the concomitant acute kidney injury and acute respiratory or acute lung injury in the famous clinical entity known as the acute respiratory distress syndrome, which is a form of acute lung injury due to non-cardiogenic pulmonary edema with acute respiratory failure, which may start a cascade of other organ failure, including acute renal failure due to acute kidney injury, which I explained in my previous presentation online just a few minutes before. So let me now talk about this closely related clinical entity, which is what we call the multiple organ failure syndrome or the multiple organ dysfunction syndrome. The multiple organ because this multiple organ dysfunction syndrome is a broader term than which also involve the acute kidney injury with acute lung injury as a part of more widespread organ system injury. The concept of the what we call the clinical concept or the clinical condition of multiple organ failure syndrome, it describes a potentially reversible physiological derangement, involving two or more organ systems not involved in the original pathology, causing the ICU admission and resulting in a life-threatening physiologic insult. So it is a form of physiologic failure involving two or more organs in the body. And this multiple organ dysfunction or multiple organ failure syndrome, which starts by two organs and then other organ systems will fail ultimately with progress of the condition if the underlying cause was not put under proper management and control. The other organs will fail sequentially, and there will be total and general organ system failure. This state of physiologic derangement or physiologic insult or physiologic failure, which happens to two or more organs, or the multiple organ failure syndrome or the MOFS or MODS, is due to major insults to the human body. Most common is trauma, severe trauma, like what happens in catastrophic events and in road traffic accidents and in car accidents and in natural catastrophes. Multiple trauma to the human body will cause MOFS or MODS. Trauma, also severe burns if the body is exposed to burn, especially massive extensive burns, due to fire, due to chemicals, due to any sort of burns to the human body, might be complicated by MOFS or multiple organ failure syndrome. Also in other severe illnesses, like in patients with, for example, acute hemorrhagic pancreatitis, like in patients with eclampsia complicating pregnancy, like also cases of fulminant hepatic failure, like also severe infections, severe systemic infections leading to septicemia and septic shock, like in severe pneumonias, like in bacteremias, like in endocarditis, like in meningitis, any organ system infection with systemic spread invading the blood with septicemia, usually bacterial in origin, whether gram-negative or gram-positive or mixed. They might also cause multiple organ failure syndrome. And usually, whether regardless of the underlying cause, whether trauma, whether burns, whether pregnancy, whether massive hemorrhagic pancreatitis, whether fulminant hepatic failure, whether severe infections, septicemias, and septic shock, there will be what we call systemic inflammatory response, severe systemic inflammatory response, or the or the systemic inflammatory response, or SIRS. That's why we call it systemic inflammatory response syndrome. And here there is a cascade of cytokine release due to widespread systemic inflammation, and this will increase the capillary permeability and also will cause many cellular changes, resulting in edema and injury here and there in the different organs. In the lungs, there will be a non-cardiogenic pulmonary edema with acute respiratory distress syndrome. And usually the multiple organ dysfunction syndrome starts in the lung, and then starts in the lung, and then other organs will ultimately failure with progress of the condition, that the lungs start what we call the MODS cascade. And then the other organs after the lungs start to fail. Most commonly after the lung, the kidneys fail, and then the heart, the brain, the liver, and the blood. These are the organs which fall sequentially and which fail sequentially in the cascade of the multiple organ failure syndrome, which happens in such life-threatening conditions and commonly met with in acute medical settings and in the critical care or the intensive care room and intensive care units. So we have to put this into consideration. What did it start the multiple organ dysfunction syndrome? We have to treat the underlying condition. We have to pay attention to the underlying condition, the trauma, the burn, the severe infection. Of course, we have to stop the infection. We have to give parenteral, that is intravenous, a combination of antimicrobial agents, mainly antibiotics, 2 or 3, and bactericidal, in order to kill and control the sepsis and the septicemia. We have to pay attention to the fluid and electrolyte management, intravenous fluid resuscitation, trying to avoid at the same time fluid overload, and trying to correct all electrolytes, especially the hyperkalemia, which is common, and also the disturbances in sodium balance, and also the trying to correct any acidosis, because metabolic acidosis is common in such conditions. So all these factors we have to put into consideration. The lungs, as I mentioned, start usually the cascade. The lungs start the cascade of multiple organ failure, and then other organs start to fail. What are the manifestations? Usually there is shortness of breathing, there is rapid respiratory rate, there is tissue hypoxia, there is hypoxemia, low oxygen saturation in the arterial blood, indicating the lung injury. There is also mental obtundation, that is obtunded consciousness, and dullness of the mental dullness due to cerebral hypoxia, meaning starting failure of the brain. So confusion is also another early manifestation of multiple organ failure syndrome. Mental confusion due to brain affection, rapid respiratory rate, and SOB, shortness of breathing due to respiratory injury, hypoxia due to respiratory injury, also diminished urine output due to oliguria, indicating acute kidney injury. So there is diminished urine output or oliguria. There is hypotension, there is cold or warm skin, depending on the etiology of the shock, which is pale, and later on cyanosed skin due to hypoxemia, severe tissue hypoxia. These are all clinical manifestations of acute respiratory distress syndrome. We have to proceed to photograph the lungs, to also chest X-ray, to investigate the kidneys and check the serum creatinine, the urea, check the liver functions. The liver may be ultimately affected with rise, of course, of liver enzymes, AST and ALT, due to acute liver injury, which of course might lead to, so the acute liver failure may be a cause or the result of the multiple organ failure in fact. And this is the liver in multiple organ failure. It might be a cause, or it might be a result, a part of the cascade of the multiple organ dysfunction syndrome. So there we have to always measure serially and frequently the liver enzymes, especially AST and ALT and the bilirubin. We have to assess, of course, other liver or hepatic panel parameters, including alkaline phosphatase and also the gamma GGT, the gamma glutamyl transpeptidase and the 5-nucleotidase, and all the hepatic panel parameters. We have to assess to observe the level of consciousness, to observe the performance of the brain by, of course, assessing what we call the glass coma scale, serially in the ICU and daily and frequently daily. We have to assess the urine output. We have to assess the cardiac functions by simple ECG, chest X-ray to see any shadowing in the lungs and any evolving lung pathology. In such cases, we have to assess the blood picture for any possible hemostatic failure, or consumption coagulopathy, which will affect the hemopoietic cells and all the cellular components of the blood. Look for thrombocytopenia, look for decreased fibrinogen, look for consumption of coagulation factors. We have to do prothrombin time, we have to do activated partial thromboplastin time, we have to do serial counts of the blood platelets for any consumption thrombocytopenia, and we have to assess the patient clinically. We have to look for and manage the underlying factor, and this is very important, fluid and electrolyte management, intravenous fluid resuscitation, avoiding at the same time, as I mentioned, overload, which increase the acute kidney injury, paying attention to the electrolyte disturbances and correcting them, including the hyperkalemia, paying attention to the acidosis and correcting metabolic acidosis, also paying attention to the kidney functions. Possible renal replacement will be needed at any time. Taking the decision to put the patient on ventilator in patients with respiratory failure is very important due to, of course, the acute respiratory distress syndrome, or to manage the acute lung injury. And at the same time paying attention to a possible deterioration and failure of other organs, and looking for any abnormal organ function tests at the level of the liver, the heart. ECG need monitoring frequently, chest X-ray frequently, possible also echocardiography we have to do. At some time we may need just CT or MRI. Possible abdominal MRI is needed also in some conditions. A frequent monitoring of the arterial blood gases, as I mentioned, the frequent monitoring of the liver function test, kidney function tests, blood picture. These are all issues which we need to follow a case of a multiple organ failure, to acutely resuscitate the patient, especially fluid and electrolyte management, and acid-based management also is very important. After paying attention to the management of the underlying condition. The burn should be corrected, trauma should be corrected. We need multidisciplinary approach usually for the management of critically ill patients with multiple organ failure syndrome. Thank you so much and have a nice day.